Hello students, starting with the topic of dentin hypersensitivity. Now what is dentin hypersensitivity? It is a common condition of transient tooth pain caused by a variety of exogenous stimuli that can be thermal, tactile and osmotic. Okay. According to the definition, dentin hypersensitivity is the pain derived from exposed dentin in response to chemical, thermal, tactile or osmotic stimuli which cannot be explained as arising from any other dental defect or disease. Whichever disease cannot be ascribed as any other pathology comes under dentin hypersensitivity. It is a chronic situation with acute episodes and it is differentiated from dental pain which is a response to noxious stimuli and is an acute condition. Okay, in dental pain, actually there should be always be the presence of some stimuli, but in hypersensitivity, it can be in absence of some stimuli. Sometimes it can be in absence of stimuli also. Like patient is saying that if the ear touches, or in the normal conditions also when the oral cavity is not active, then also it will show some of the conditions like sensitivity. Now, other terms used are dentin hypersensitivity, cervical hypersensitivity, root hypersensitivity, and segmental hypersensitivity. Etiology, it is basically due to exposure of dentin and presence of open dentinal tubules on the surface. It can be of two types, sudden pain at an isolated site or generalized hypersensitivity. Causes are loss of enamel, parafunctional habits like occlusal wear, toothbrushing abrasion, dietary erosion, denudation of root surface like gingival recession, aging, chronic periodontal disease, abnormal position of tooth in the arch, exposure due to periodontal surgery, and incorrect toothbrushing technique. Now, these are the various causes. You can see here various causes: erosion, cervical abrasions. Now, what is the mechanism? Mechanism can be described on the basis of dentin, that is the conduction of pain through dentin, direct innervation theory, odontoblast receptor theory, and fluid movement or hydrodynamic theory. Now, what is direct innervation theory? It was the first theory proposed, and it says that there is direct innervation of nerves in endings within the tubule that lead to dentin hypersensitivity. But histologically, we cannot prove there are direct nerve endings till the DEJ. So it was disregarded. Now, this is the direct nerve stimulation. You can see nerve is directly up into the dentin. Now, odontoblast transduction theory. According to this theory, it said that odontoblasts are related to the conduction of pain. But if odontoblastic process, if we see, they are only up till the 2/3 of the the dentinal tubule. So how they will conduct the 1/3 area? So that is why it was later on it was also rejected. See, according to the dentinal tubules. Now, next is hydrodynamic theory. It is universally accepted, and according to this theory, the pain transmission is through rapid movement of fluid, that is the dentinal fluid present in the odontoblastic tubules, and that leads to the flow of sudden, when there is exposure of dentin, the dentinal tubules are open, and sudden changes like temperature, any other stimuli like osmotic, that is sweet, sour, etc., will lead to the sudden flow of your this dentinal fluid, and that will lead to pain. This is the hydrodynamic theory. Now, how to diagnose? First, medical dental history you have to take, proper pain history you have to see. Then degree of pain can be qualitative or quantitative, which can be analyzed with the visual analog scale also. Then various differential diagnoses there are. How to ascribe that this is dental hypersensitivity? First of all, we will check for all these things. When there is no such related pathology, then only we are going to ascribe it as dentinal hypersensitivity. The causes which lead to hypersensitivity are different. When there is a frank cause, that there is a cervical abrasion and there is a secondary dentin hypersensitivity. But when there is no cervical abrasion and the abrasion has initially started, it leads to open dentinal tubules and it will cause dentinal hypersensitivity primarily. Now, what is the treatment planning? Removal of the causative agent. whatever improper brushing, premature contact, gingival recession, any exogenous acid that are leading to erosion, we have to do that. Then removal of endogenous acids also, poor oral hygiene, coolant spray, all these things are done. Then various desensitizing agents are given, like they should have rapid action, long-term effect, harmless to pulp, painless, easy to apply, should not stain, consistently effective, and target both underlying cause and symptom. Okay. Now, according to the classification, the administration can be at home, in office, and on the basis of mechanism which disturb the neural response to pain stimuli and which occlude the dental nerve. On the basis of these two, various agents are classified, right? Some will disturb the neural response, that it will lead to there won't be any further neural activity in the tubule, but some will occlude the dentinal tubules, which we are presuming that is more effective, that we are not causing any harm to the nerves. Now, at home therapy, what dentifrices and toothpaste you can give over the counter, which is present in the market, okay, and sometimes it may contain arginine, calcium carbonate, and fluoride, etc., and these are recommended to use with minimum amount of water, so it is not diluted. Various presents are like various brands are providing, like Thermodent, Colgate, Sensitive Pro Relief, Sensodyne, High Aura K, okay. Then at home therapy includes mouthwashes and chewing gums also, okay. The 2 to 4 weeks for home therapy we give it to the patient, and if it still exists, then next phase is done, that is at office. See, we can see the mouthwash. Okay, in office therapy, what are the various agents used? First is the potassium nitrate. It can be present in an aqueous gel or adhesive gel. What is the main mechanism? The potassium salts act by decreasing the diffusion of potassium ions into the dental tube. That is, it is acting on the nerve, okay. It is of that mechanism, okay, potassium nitrate gel. Other one is fluorides. 2% sodium fluoride can be used, and acid is also added, so it can be acidulated sodium fluoride. Now, what is the helpful is that it has the same effect, stannous fluoride and sodium fluoride has the same effect, and it precipitates as insoluble calcium fluoride, which occlude the dentine permeability, that is, they are occluding, okay. See, some iontophoresis of sodium fluoride can be done. Now, another is oxalate. These are the most commonly used, and they can occlude 98% of the dentinal tubules. They are very effective in dentine hypersensitivity, okay. Some adhesive resins can be used. They form removal of smear layer and etching in them, and then hybrid layer is formed. This will occlude your your dentinal tubule, okay. Now, in office includes various varnishes like copal varnish, and dentin bonding agent like gluma desensitizing. This is also very important, very useful these days. Hema, which is used in your composite, it can also occlude the dentinal tubules. Now, most important is the bioglass, that is calcium sodium phosphosilicate. It is very biocompatible, and also it occludes the dentinal tubule with the formation of your apatite layer, okay. Apatite layer is formed here. See, bioclass C, okay. These are the open dentinal tubules and these are occluded tubules. Now, in office therapy includes Portland cement and CPP, ACP also. We have studied about this in our caries preventing tooth mousse. GC tooth mousse is available. This is the GC tooth mousse. With the help of lasers, we can what happens with the help of laser, through coagulation, the protein inside the dentinal tubules are precipitated and they occlude the tubule, okay. Nanohydroxyapatites are used. It is the most biocompatible and bioactive material, and it has gained wide acceptance in dentistry, okay. This you can see. Now, for diagnosis and treating of probable etiologic factors in causation of dentinal hypersensitivity. First, for mild to moderate sensitivity, you will teach the patient the correct method of tooth brushing and first initiate the home treatment. And after 2 to 4 weeks, if it persists, then in-office treatment you will do. And if it is higher, severe hypersensitivity is there, we will directly start with in-office treatment. So various in-office treatment we have studied, APF gel, fluoride varnish, gluma, GC tooth mousse, laser therapy, etc. Okay, accordingly. And if it has reached to a higher extent that the pain is not subsiding, then ultimate resort is your root canal treatment. With this, we can conclude the dentin hypersensitivity. Thank you.